Hey everyone, welcome to the first episode of the Medical Fitness Podcast in 2025. The Medical Fitness Podcast is powered by the Medicine Rehab Fitness Institute and the Medical Fitness Association. I'm Jeff Young, a co-founder of the MRF Institute, and I'm here with my two friends and colleagues, Dr. Thomas Hammett, who also co-founded the MRF Institute, and David Fletch, CEO of the Medical Fitness Association. Hey Thomas, hey David, I'm excited for today's discussion.
Hey Jeff, good to see you. Welcome to 2025. I'm looking forward to this as well, and a lot of fun stuff to talk about today. Thomas, how you doing?
Yeah, I'm great. Yep. I drew the short straw today, so I get to do our long intro. But what really happened for the listener, the three of us, Jeff, David, and I have spent really the last couple of years interviewing some really incredible people, having some good conversations about like some of the deeper topics in the world of medical fitness. And in a conversation amongst the three of us, we thought there was an opportunity to go a little bit deeper into the why behind medical fitness. Why does a medical fitness service even exist, and what that looks like, and how it's being done in different places in the United States. Almost going like if we could go back and start over again, how we'd set the stage from day one. So what I'll do to start this episode is give some background on that why, and amongst the three of us, we're going to do our best to share some stories and talk about our perspectives from our own experiences in medical fitness. So here's where I want to start. Really, when we look at the global health and fitness market, in 2023, it was a $112 billion industry. The United States alone accounts for about $22 billion, or about 20% of that. And that's according to the Health and Fitness Association, formerly IHRSA, via John Dunham and Associates. This is globally projected to grow to over $200 billion by 2030. For anyone listening, to me, that's a huge industry. It's big. And when we think back historically, most modern gym chains didn't open until really about the 1980s. The number of private fitness clubs grew from about 3,000 in 1978 to over 20,000 in 2002. Memberships increased from 1.7 million in 1978 to over 42 million in 2006. Really, hopefully, just giving you the context that this is a massively growing industry. The digital fitness industry alone is generating a lot of the new growth. Expected to generate almost $15 billion in revenue this year, and over 50% of Americans report using some form of digital health solution. So just to give you a picture, health and fitness is a huge market and industry. Unfortunately, we have this coinciding overlap of time where between 1980 and today, health and fitness has grown. But so is chronic disease. And this is one of those unfortunate two things happening at the same time. How do we explain it? Since the 1980s, chronic disease has grown a lot, now affecting 6 in 10 Americans. And a number of factors contribute to this health change, including the abundance of highly processed foods, increases in sedentary work and leisure activities. I could go on and on. There's a lot of stuff here, a lot that's been published in the last few decades around this phenomenon. Less than 1/4 of Americans meet the physical activity guidelines for cardiovascular and strength training, according to the CDC. And typically those estimates are based on self-reporting, which we know tends to overestimate physical activity self-reporting. So we want to be careful here. We don't want to make the conclusion that the health and fitness industry has caused anything like this, right? Of course not. But there is this unfortunate overlap where in the past 50 years, financial spend on health and fitness has gone up and chronic disease outcomes have gotten worse. Accessibility of health and fitness solutions have also increased despite the lack of public health improvement. So some other things that we need to think about as part of this picture. And if we think about the origin stories of health and fitness services, much of what health and fitness services have been developed on has been tailored to the athlete or the individual seeking physical performance. This is a segment of the population that typically isn't thought to be the people suffering from chronic disease. And what's available largely to people who are not that the athlete are weight loss programs, which may or may not meet people where they're at, and may or may not be a conversation we can get into deeply today. But the alternative of the athletic program is a weight loss program, and that likely isn't meeting a lot of people where they need to be met. When exercise is performed consistently and dosed appropriately, we know research has repeatedly shown it can have a potent health effect on chronic disease and longevity. It should be a major part of the equation for improving health. We just need to figure out how to incorporate it for the right people in the right way and at the right time. There are lots of opportunities for creating a more active public, a public that exercises in a way that optimizes health. And this is really where the medical fitness solution becomes relevant and important. I think the last thing that I want to say in our intro today is that when we talk about the health picture related to chronic disease, there are so many different things that need to be talked about. Like, we need to think about systemic changes, like making cities more walkable, business opportunities like digital tools that make exercise more accessible, medical solutions like improving physician advocacy for physical activity and exercise, community solutions like community centers. This is a big topic, but really the three of us have specific expertise on how exercise can be tailored as a medical solution to people who are struggling with real health issues. And that is what we intend for the most part to talk about today. So I've been talking a lot. I want to give the stage back to first see Jeff, David, is there anything you want to add in terms of the origin story of the background? And then we'll talk a little bit about our own stories and how we got into medical fitness. Anything you want to add to what I just shared?
Yeah, Thomas, I think you did a great job of kicking this off. A lot of those statistics, I don't think people are surprised at hearing those and probably have heard similar things. I commonly, in some presentations that I do, talk about these CDC maps of obesity rates. And I recently put one of those together that it's amazing looking at the very first one that he did back in 2011. 75% of states had less than 30% obesity. And so you fast forward that to 2021, even it was from 75% up to or down to 15%, however you want to look at that, had more than 30% obesity. So it's yes, it's getting worse throughout that whole time. Obesity certainly, one of the big health related factors that exercise and healthy living can improve. So it's not a matter of lack of knowledge right now, right? People know what makes them unfit, unhealthy, and things that help them, like fitness programs, nutrition, etc. So it's not for a lack of knowledge. It's a lot of these other contributing factors that you mentioned a little bit. I look at things personally a little bit more from the healthcare side of things. Of my career has been spent working for wellness centers in hospital-based fitness and wellness centers, and so the exposure to understanding how healthcare looks at this also is part of my background. And 16 years ago, I think it was, the Institute for Healthcare Improvement came up with a triple aim, talking about population health, experience of care, and per capita cost of healthcare. And that's really when some of this population health stuff started coming about as a result of that IHI reporting. But really, that didn't make any movement happen either until healthcare started looking at the payment mechanisms. They attached dollar signs to the solution, and that started to move the needle. You talk about the framework for payment reform and category 1, category 2, category 3, category 4 payment mechanisms, where one was just that fee for service. And so, healthcare was getting incentivized to just do more procedures, more testing, more imaging, more everything. And then, it's moving towards population health and the bundled services and spreading the risk, value-based all of that. We could talk forever about those sorts of things, and I don't want to get too deep into those, but just kind of looking at it from that standpoint, healthcare really had no, there was not a lot of incentive to change, and still until some of that those payment mechanisms started to move, and so we're seeing some of that now. It's definitely not where it needs to be, but as part of what I do now for the Medical Fitness Association, helping provide resources and guidance and the model of how to do things within this new world. We are starting to see some of those changes, and so the model, we can talk about that as part of this conversation today. Um, I think some of those statistics, though, of talking about the changes in how healthcare systems are looking at things, accountable care organizations, and really just a lot of that sharing of risk, I think, is important to understand as well. Jeff, do you have anything to add?
Yeah, actually, I really don't, but I do think that maybe this would be a good opportunity for the three of us to very briefly just mention our origin story. Maybe you could actually start, David, because and piggyback off of everything you just said, because you and I work in the same world, and yet we work in different worlds as we're getting ready to. The listeners are getting ready to see as we get more into discussion. So I'm actually curious, and for the listeners' sake, how did you get into all this? And then maybe I'll follow up with real quick with my origin story is, and then Thomas can do the same, and then we'll get into the questions.
Yeah, well, I'm right here on the 4-year anniversary next month of my time as president and CEO of the Medical Fitness Association. Before that, I spent a little over 20 years running medical fitness centers, hospital based. So I alluded to that earlier just a moment ago. But if you take me all the way back, my high school years, very much into sports and athletics, and got interested in physical therapy at that point. My father was a pharmacist at a hospital, so I did a lot of observation of physical therapy in various settings, sports medicine, inpatient, outpatient, etc. Went to college and thought I was going to do physical therapy, but learned of exercise science. So went through that program, and one thing I'll mention is I worked during college at a community recreation center. Great opportunity. I think that's something that I encourage every young person who's starting their careers to really start to not just work at a place that pays them a paycheck during college to have some spending money, but or pay for college, whatever it is. Find something in the industry that you're trying to get into, because that really puts you ahead of things. So that helped me there. But I also got an internship with Ohio State athletics and their strength and conditioning department. I'll just real quick anecdote of the story from when I started with the Ohio State strength team is that the head coach of strength and conditioning required me to have perfect form of my Olympic lifts. And I had never done those before. I'd always, just done general lifting techniques, but so they were real big on the hang clean and jerks. And I had to do that probably a few thousand times with a wooden dowel that was maybe it was 3-4 pounds. It was nothing, and it felt ridiculous to do, but I did. I perfected that motion so that I could then teach the athletes that. So we talked a little bit about athletics as part of the fitness industry, and yeah, that's a big part. And that I have some of my origins in that. Went to as soon as I graduated with an exercise science degree, I went to work for the McConnell Heart Health Center in Ohio. Yeah, it's a medical fitness center. Just that was back in 2000, I think, starting there as an exercise physiologist, and so working in that model fairly early on in the industry, I would say. One of the I would consider best places in the country to get your feet wet, and got into leadership there, and realized if I'm going to lead these types of organizations and departments, etc., I need some business background too. They don't teach that in exercise science school. So I went back, got my MBA. I'd say that was the other point that really helped me out in my career. And then, yeah, I was able to progress through different medical fitness centers, and really that's where my expertise was developed to the point now where I get to really help facilities all over the country who are trying to put this model in of medical fitness centers.
Awesome, man. It's just again, you've heard me say this before on previous episodes, but I just love hearing people's origin stories because it's just so intriguing to me. Let me quickly say mine, and then we'll pass off to Thomas, and then we'll get into the meat of the discussion. For me, yeah, I never thought that I would get into something like this. It was not part of the game plan. I actually didn't really know what I wanted to do when I was a junior and senior in college. I went to Penn State for my undergrad, but I was involved in what at the time was the longest strength and conditioning study ever performed by someone who's been a previous guest on our show, Dr. Bill Kramer, who's widely considered the premier strength and conditioning researcher in the world. And the reason why I say that is because as we get more into our discussion today, the listeners are going to see that I've kind of just maintained this strength and conditioning coach mentality and perspective. And that's how I even look at medical fitness through that lens. So that really started off my medical fitness career without realizing it. And then my first job out of college was at Duke Medical Center's Diet and Fitness Center, which is medical weight loss. And they had medicine, um, fitness, nutrition, and behavior component, which is the 4 out of the 6 pillars of lifestyle medicine, and it was medical fitness. So again, we didn't call it medical fitness back then, but here I was in a medical fitness atmosphere without really realizing that this is how my career was going to evolve. And then you flash forward to 10 years to 2006, and I was brought on to be the founding fitness coordinator in a Mount Sinai facility. It was actually started off as Beth Israel facility in New York City, and then we merged with Mount Sinai. And during the 10 years I was there, that's when I just became immersed in medical fitness. And as David knows, our medical director he started the physician track at the Medical Fitness Association. So he's actually the one who introduced me to the phrase medical fitness, and that our facility was a medical fitness facility. And then that's how I learned about it. Eventually became involved with the Medical Fitness Association. Pandemic comes. Mount Sinai had shut the place down. I had to reinvent myself. Went back to school, got a master's degree in exercise and sports science with a focus on strength and conditioning, despite at this point being well into 25 plus years in my career. Again, I still consider myself a strength and conditioning coach who works in clinical settings. More on that later. And now I'm in a doctoral program and pursuing an EDD in kinesiology with a focus on strength and conditioning. And then lastly, I'll say I consider myself an entrepreneur at this point. I have a startup with Thomas and Sheila with the MRF Institute. I teach courses at CUNY, the City University of New York System, York College. I teach strength and conditioning. I teach exercise prescription for special populations, which is the chronic disease side of medical fitness. I teach intro to sports medicine and rehab, which is the musculoskeletal side. And I teach nutrition and health and a weight training class. So to sum all that up, I've had this windy career that has been, I think, unique and a little bit unusual. But the one thing that's really stayed the same is my focus, starting from the whole Dr. Kramer study back at Penn State and periodization and all these things that has never changed. And I've always been just this, we need to optimize programs and get people fit, et cetera. But more on that later. But there's my origin story. And Thomas, I'm looking forward to hearing yours.
Yeah, thanks, guys. Two tough people to follow in this conversation. What I'll say. There are two things that really drove me really to the place where I now identify myself as someone who's deep in the medical fitness world. Um, First was I fell in love with exercise as a kid. I think that more than anything else is a starting place for me. That what I think we would call blowing off steam as a teenager. Back when I was a kid, was like dealing with anxiety kind of stuff with iron, and I fell in love with exercise for personal purposes. The other side of this for me is that I was lucky enough to go to a really unique graduate program for physical therapy school. So obviously in this mix, I'm the PT of the group. Um, I went to Duke University, not intentional that Jeff and I always shout out Duke together, but shout out to Duke University for being a good institutional learning. In the time that I was at school at Duke, I had a couple of really unique experiences from a global health standpoint. In particular, I did a clinical rotation in Norway for 13 weeks, as well as attended a global health conference that showed me what a lot of people across the world were doing for rehabilitation. And what surprised me compared to the United States model of rehabilitation, which is so focused on the impairment, fix the joint, fix the muscle, fix the whatever is going on, the disc, right? Um, was that so much of global physical therapy is teaching people how to exercise at a more global level. Like, we don't get into the minutia. So much of it is advocacy for getting people moving. And I don't think I knew that that existed before PT school in the PT world. And when I got out of PT school, I was a little pessimistic on this idea that I would ever find a career that I could actually do that working for someone else. I got really lucky though. Starting right out of school, I went back to my hometown, started a job at a place called Pinnacle, and they were doing some things in terms of thinking about the pathway through physical therapy to get people both opportunities to improve their health via nutrition, but also getting started with exercise. All those statistics that I talked about before, um, they they make such a big impact on the physical condition. If you're not moving your body, if you are in a state of poor health, you're more likely to get injured or experience pain. And that for me was so much of the purpose of thinking about how do I get people into exercise and what does that exercise look like to change their behavior and change their lives from a health standpoint. So that's my background. I now am the director of operations for sites across the United States that are running a medical fitness program called Lifestyle 365. And so much of our focus is on prescribing exercise that meets those people where they're at and understanding the impact of that exercise on their health. So that's me. I think we're ready, guys, to get into some of the details of this stuff. We've introduced the background and why a medical fitness service should exist. I think we've good enough explained why we should be the people talking about it. And I'd love now for us to start with the question, what does a medical fitness solution offer compared to a more traditional fitness solution? And maybe what I do is pass it. Jeff, are you okay getting started with that one?
Actually, if you don't mind, I would love to hear David first, and I'll piggyback off David.
Great. Yeah, so this question I've got so many times over my career. What is medical fitness and how is it different and those sorts of things. I can remember even starting my last director job at Hancock Wellness here in Indiana. And we had a town hall meeting because we were changing a traditional fitness center that was owned by a hospital, but just kind of ran as a fitness center into a medical fitness center. That was announced, and that was kind of why I was there. I was coming in to put that model in place, and there were a lot of misconceptions over what it was and what it is. And so it was actually kind of nice having that opportunity to talk to the membership, the community, and talk about it. And one thing that I like to say about medical fitness is it's really, in my mind, it's a layer on top of your traditional fitness center. So most of the aspects of a traditional fitness center still exist. And in fact, all of the equipment tends to be, maybe not all of the equipment, but a lot of the equipment tends to be very similar to what you find at other type of fitness centers. Um, it's really then the programming, the staffing, and a lot of the what is done in that. So it's another analogy is the hardware is very similar, the software is very different. So it kind of adds this layer on top. People don't have to be afraid of losing their high intensity interval training programs, their boot camps, their personal training, their Zumba classes, their all the different things that they tend to love in a traditional setting still happen in medical fitness, but a lot more happens. It's these layers on top. And so one of the things I talk about a lot is the foundation really, I think, is medical oversight. So having some type of either a medical director who is a liaison to the medical community, who can provide some oversight, guidance, recommendations, especially on some of the programming that happens. having the qualified staff. A lot of times, just your traditional fitness centers maybe has one, two folks that are highly qualified or somewhat qualified, and then a lot of people who may not have the appropriate qualifications. So degrees in the field, accredited certifications, advanced education and training in certain areas. That's important to put into place, especially as another piece, the integration within programming, within personnel, and all of that, which I refer to as clinical integration. So having the programs that are for specific populations that typically would not be comfortable in a regular fitness center as well. So you're creating an environment program that addresses their needs, whether that be cancer exercise, Parkinson's, diabetes, hypertension. The list can go on and on, right? And so having some of these programs where you have specialized staffing that can address those issues, that really right there is the foundation. And then a lot of other things still happen within this model. Outcome tracking is huge. Emergency and safety training is really huge. Pre-screening and having your staffing be able to prescribe the right type of program and progression through that program. Those are all important. So there's a lot that goes into it, and maybe I'll stop there and let you guys kind of react and add to that.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association, helping fitness professionals and medically integrated fitness centers achieve their full potential through education, certification, and networking opportunities. Join today and elevate your career with the Medical Fitness Association. Visit medicalfitness.org to learn about the many benefits of membership offered by the Medical Fitness Association. That's medicalfitness.org.
Yeah, if you don't mind, I'll react first, and I'll start by saying that yeah, I should have gone first because yeah, you just stole my thunder. But you know what? It's not surprising because we obviously work in the same field. We have slightly different perspectives, but the Venn diagram probably merges way more than the parts that are different between the three of us. So in my response, I'm going to say probably mostly the same thing, but maybe just bring a little bit of a different perspective to it. So again, the question that Thomas had asked was, what does a medical fitness solution offer compared to a more traditional fitness solution? And when I see that phrase, more traditional fitness solution, I think of the health club industry. So when you formed that question, I don't know if that's what you were thinking about, but that's what I think about. And the fact that the health club industry really dominates, like when people think about fitness, they typically think about health clubs, even though there's also corporate fitness, medical fitness, strength and conditioning. There's academia. So there's other components or sectors within it, but people mostly think of health clubs. So in any case, I'm going to say a lot of the same things, but again, maybe from a different perspective. And I am going to go back to Penn State and when I was a student. And so I'm sitting in class as a junior and a senior, and I'm learning about this concept called periodization, which some of our listeners may be familiar with and some may not. But the gist of it is it's a concept that was developed way back in the 1960s and 70s as a way to develop and design programs for athletes, and more specifically seasonal athletes. So you had a long-term plan, like for an Olympic athlete, you had the four-year game plan. You would break that down into like a 1-year plan, 3-month, and then ultimately down to your session. So we were learning that in class, and we were learning that periodization applies to athletes and to get them ready for a performance, etc. But then I'm involved in this study with Dr. Kramer, leading the charge, and the participants in the study were not athletes. They were general population. And it made me realize as I was going through the study that, oh, these concepts aren't just for athletes, they're actually for the general population too, because again, we all manipulate the same variables, whether you're a physical therapist like Thomas, or a strength and conditioning coach, or a Pilates trainer, or I'm sorry, yeah, Pilates coach, trainer, whatever they like to refer themselves as, or whatever the case may be. we all manipulate the same variables when we're designing a program, whether it's the frequency that someone's going to work out, the volume, the intensity, etc. And then, as I mentioned previously, with my origin story, I then start working at Duke Medical Center, and now I'm in medical fitness, and I'm fresh out of college. Actually, it started as an internship, so I'm technically still in college, and I'm realizing right away, wait, this periodization, these concepts apply in medical fitness as well. And at that point, and also the fact that I had maintained a mentor-mentee relationship with Dr. Kramer, so I was having regular conversations. Through all that, through my learning in school and my experience, and also conversations with Dr. Kramer, and also colleagues at Duke who were following the same type of approach, I realized that, you know, I actually wasn't able to compare it to the health club world because I wasn't in the health club. I wasn't exposed to it yet. But I did realize that this is the way to go about things. And then I moved to New York City, and now getting more specifically to the question, and how does it, how does the medical fitness solution, was it offer compared to more traditional fitness? And as it relates to what David said, I look at it as it offers a higher standard. And I'm just going to be blunt and say that. I think it's a higher standard. And you need a higher standard in order to gain the trust of healthcare providers. You need that higher standard. And then it involves all the things that David mentioned, whether data collection, that feedback loop, et cetera. But ultimately, I think that you can break most, not all, because there's the organizational component, which David is a master of, and Thomas, you as well. Me, not nearly as much as both of you. But I think that you can kind of break down what medical fitness offers into there's the clinician side of the fence, and there's the fitness trainer side of the fence, and that there's a trust gap that exists in between the two. That trust gap isn't being met for the most part in the health club world. And so they aren't really offering that for the most part. Whereas with medical fitness, we are. And we're addressing both sides, or we're at least trying to address both sides of or I should say, problem solve at both sides of the fence through. Okay, so what do we need to do in order to gain the trust so that we can have relationships with healthcare providers and get those referrals, and then have the staffing, which obviously is part of the trust gap, to design higher level and higher standard programs to help with the trust, et cetera. Collecting data along the way, getting that feedback loop going, and closing the feedback loop along the way, et cetera. So I just feel like medical fitness really applies to everybody because it's programming, it's programmed the right way, but we're just applying it to people who fall into that special populations category. But ultimately, I think there's a ton of similarities, but what makes medical fitness different is it's just a higher standard that does a lot more problem solving, and that ultimately really wants to connect medicine and fitness for the purpose of improving individual health and ultimately public health. So there's my response.
Great, Jeff. What I love is you kind of tied back to the conversation we were having before this call, that the algorithm is very similar across different special populations, even outside of special populations. What I'd say when I created this question, I appreciate you going back to what the question is. When I created this question, I was thinking of, if you're a person showing up to a health club versus a person showing up to a medical fitness facility, what kind of different experience should you expect? And, the person showing up to a health club, particularly, think about the people that need medical results out of exercise. They may show up to the health club and get on the treadmill because they're looking around and they see that that's what other people are doing, and do some treadmill time and hope that that's getting them some kind of result that is going to lead to some weight loss and make them feel better because they're doing the exercise thing. And I think this happens this time of year at health clubs across the United States, and people are really showing up and trying and doing their best to get a result out of investing the time and exercise. And the reality is, this is where the statistics early on come in. People need more support than that. So to me, like, the essence of what a medical fitness solution can provide people is just, and to summarize in a more simple way, but Jeff, you gave all the details that matter. They need guidance. They need a program to follow, right? When you show up to a health club, you may not get that. Or if you do get it, it may look like personal training. And then we talk about, like, there needs to be a layer of safety when it comes to medical fitness. And this to me is just like, it's a blanket term, but it's the term that medical providers like, is to know that there's safety. Go to any hospital website, it's going to be a pillar or a value somewhere in there, right? Is safety or high reliability. And what I mean by that is when exercise prescription is given, we assure that medical conditions are managed and considered as part of the exercise program, that prescription is appropriate to a person's fitness level, and that outcomes are achieved in an appropriate way. This almost like the opposite of the crash diet crash kind of situation, right? Where a medical fitness provider would be expected to help people do it in a safe way. I also think, maybe the last thing that I'll mention as part of the medical fitness solution that I think just has to exist at some level, is, and I don't necessarily say this as it needs to exist. It should exist today, but I think it's going to need to exist moving forward for a lot of the reasons of payment that David was mentioning before. Outcomes testing and data needs to be acquired to show that those fitness programs are leading to health change. Like it's part of the future of what is going to be asked of any medical service, period. And if fitness intends to be a part of the medical pathways, whether it's reimbursement directly or indirectly, they're going to need to show that exercise in the way that it's being performed leads to a medical outcome. And if that doesn't happen, I think a lot of people lean on the exercise is medicine blanket statement. We got to prove that the exercise that we're doing at our medical fitness facility leads to that change. And so much of that to me is just collecting the data. If people are exercising, they're going to show health improvement. I think I feel really confident saying that. Data collection is hard though. And medical programs are going to need, I think this is more of a need rather than a current state everyone's doing this kind of answer for the outcomes testing and data side. But that to me is really the what that makes medical fitness unique.
Love it.
So we've talked about what medical fitness can look like. I think as a part one, we'll come back to more of the what. We decided planning this, and David pointed this out, I think, really well, that if we do a why, how, what kind of structure, that hopefully people will be able to follow along our organizational pathway. So we're gonna bounce back to a little bit more of how medical fitness is delivered, and get into some of those details. The next question that I have is, who is involved with the delivery of a medical fitness service? And this, like, thinking a little bit more on the staff guideline. Maybe David, do you want to start? Jeff?
Yeah.
Go ahead, David.
Well, just first of all, yeah, that the what, the why, the what, the how. I mean, we started off with the why of all those statistics and the reasons and what's going on, and kind of describe of what it looks like from each of our perspectives. So yeah, that leads directly into the how. And in terms of the staffing, in my experience, exercise specialist, exercise physiologist, whatever you want to call it, somebody that has typically a degree in exercise science, kinesiology, some related field like that, are some of your main providers of the service in a medical fitness center. So they're the ones doing the initial appointments, running programs, follow-up appointments with the members and participants of programs. But then there are several other staffing models. What we typically would do is we would try to incorporate registered dietitians for the nutritional aspect. All of the facilities that I managed were integrated with physical therapy. So you had PTAs and physical therapists that were, they were directly working with their patients, but they were also integrated within everything that we were doing. And so you had that. You obviously have your group exercise folks, and so the need for certified instructors. And we always made it a point, if you're going to teach a specialty class, you have to have a specialty certification that addresses that. And so that was important for us. And a lot of our facilities had massage in them, so licensed massage therapist. Again, I think you can probably hear the the backbone of this is you have to have training in what you're doing to really be and working in a true medical fitness center. So just unfortunately for some people, just because you like to work out does not qualify you to go out there and give advice. And or just because you're a celebrity doesn't mean what you've said on TikTok is really the right thing. So, I could go on and on about different, staffing solutions. A lot of our facilities had diabetes education programs. So you'd have maybe a nurse or a certified diabetes educator who was a dietitian. I think a lot of it is driven by the programs that you're offering. And then the programs that you're offering are driven by the community that you're served, the organization that you're part of, those sorts of things. So, Jeff?
Yeah, honestly, you nailed it. I will probably my answer will be short, and it will just reinforce what you said. And I'll use like Mount Sinai as a primary point of reference. We had obviously the from a fitness standpoint, and the hospital requirements were you needed to have a degree in exercise science or a related field to even be considered to be staff member. So again, it needed to be exercise physiologist or kinesiologist. You had to have a higher level cert like ACSM, NSCA. At the very least, you had to have one or both of those, etc. And then from the clinician side, we had family medicine, we had internal medicine, orthopedists, physiatrists, physical therapists, occupational therapists, podiatry, we had nutrition, we had the behavior side. I've worked at UCLA and Beth Israel's Diabetes Institute. So yes, we had the endocrinology and the nurses and physician assistant and everything that you rattled off. So there tends to be a commonality with and also physical therapy, obviously physical therapy, chiropractor, occupational therapy. I don't want to, it's kind of goofy that I even forgot that, because for 20 years I've been working alongside or in the midst of the sports medicine and rehab atmosphere. So and I'm a co-owner of the Medicine and Rehab Fitness Institute. So obviously we want to think about that pathway as well. But in any case, it's just reinforcing what you just said. And I just think that the only other thing I'd like to add is that there seems to be a commonality with the type of clinician that tends to be involved, because there's a zillion specialties out there, and the type that's involved seems to be, you could probably narrow it down to 15 or 20 common practices. But otherwise, that's my response to the question.
Yeah, I think and David, what I really loved about what you said in terms of it matters about the program that you're running or the programs that you run, because I think to think of medical fitness in isolation, it doesn't really exist often that way, right? It's typically offered in multidisciplinary formats based on the program, right? So if you have a diabetes management program, exercise is not the only thing that's going to make medical difference for, from a lifestyle perspective. There's going to be someone else that the fitness professional is going to collaborate with to help, promote better management of that patient's diabetes. And a lot of the time that's, a registered dietitian or nutritionist. Certainly other medical providers may be involved. I think so much of, when you think outside the service, a lot of the other people working in and around medical fitness are the referral pathway into the service itself too. For me as a physical therapist, that there are times that I'm working with a patient at the same time as they're participating in their fitness service. And I think that's really great when that happens. A lot of the time, my role is to be the conduit to get that person participating in a lifelong exercise program, which means that their work, the patient's work and exercise should exist beyond me and should transition at some point into the realm of the fitness professional that's running the program. So like at a simple level, I think there's the referrers and the receivers of this situation, and the receivers end up being, as you guys have talked about, the qualified fitness professionals or people who run a fitness program that's intended to be, tailored to those people that need that kind of service. So, but I appreciate, David, really thought your point was great that, a lot of these medical fitness services are delivered as part of a multidisciplinary program for a condition or for promoting a certain health outcome of some kind. So that's great. Uh, Next question I have on my list is on the other side, who is the ideal candidate for participation in a medical exercise program, or kind of in other words, like who's the market? Who should be who should be getting these kind of services?
If you don't mind, I'd like to tackle this first, mainly because I'll be short, and I'm curious what David's response to what I say is. That's the reason why. And so my response to this is, and correct me if I'm wrong, but if I remember correctly, when Doug Rively was on, I think he tackled this a little bit and said that that the I don't know that he was coming at it from an ideal candidate standpoint, but he basically said the demographic tends to be like 50 plus,
Mm.
or I can't remember if he said 50 to 65 or whatever, but he definitely gave an age demographic, and while that has been my experience without a doubt, so I don't disagree with that, but because, as we talked about at the beginning of this podcast, with the health of this country is just getting worse and worse. We spend more and more money, and the health of this country gets worse and worse. And it would seem to me, logically speaking, that that demographic is probably going to widen, and maybe it happened. The age demographic is probably going to widen, and maybe it hasn't yet, and maybe you're not seeing it in medical fitness facilities yet. But if we don't do something, then I think that unfortunately that demographic is probably going to widen. And also, just because I think my bias is that the way we approach medical fitness is also how we should approach prevention, or at least very closely. So, in other words, health clubs should be doing a lot of the same things that medical fitness facilities are, just to have a higher standard. Um, yeah, I just think that the again, going back to the question, let me remind myself here, because I lost my train of thought. Who's the ideal candidate? I just think that uh, we need to address this a little bit better. But the age demographic is potentially going to widen, even though currently it might be in that 50 to 75 range or something like that. So I'm
Mm.
curious your thoughts on that, David.
Yeah, and I think to bring that back, that was probably a little bit more of an average age.
Okay.
So as all averages, you're going to have a bell curve maybe, or
Yes.
something like that. A lot of people even are saying their services at a medical fitness center are what is it, cradle to grave. So really can address all ages. But yeah, I remember our average age was very similar. I think it was upper 40s at most of my facilities. So it's basically myself, and all the health things that I'm experiencing right now, which not as many as a lot of people, but still, you start to get into this, so you get this perspective, a new perspective. But that type of age, yeah, that's your average maybe. But you can talk about so many other factors of demographics. And one thing that we liked to ask our members was, have you ever worked out in any type of fitness center in the past? And some facilities, it was more than 50% of our membership had never worked out in a fitness center before. Which are, there's some really good things about that. So it's generally in a medical fitness center, I would say, generally speaking, maybe 40 to 50%. And again, it depends where you are, and who you're serving and all of those sorts of things. But in terms of the ideal candidate, I think it also can come back to the starting why that we talked about, and the why medical fitness is needed, and some of the poor health that our country and all over the world really is experiencing. And traditionally, what has happened is fitness centers have served a narrow market, an athletic market, maybe a bodybuilding market, but an apparently healthy market that is working on things that is it's not the rest of the population. That's where you hear that we serve the 20% of the population, and that's why there's still such a big problem with the health of our nation and world. And so I think part of what medical fitness, one of the things that we really put an emphasis on was making it an environment that people felt comfortable in. So there's a lot of ways to do that. But one of the things that we did is we wanted to make sure our free work weights went right up at the front as you entered the door, because that can be intimidating, especially for somebody who's never come in and worked out before. Oh, look at this guy. He's deadlifting 500 pounds. Okay, that's not me today. A lot of people are saying that sort of thing. So, some other, more friendly environment as you're coming in, really putting an emphasis on the intake, having a comprehensive health assessment, and taking people through an exercise prescription and getting them comfortable. Because if we are if the medical fitness solution does offer cast a wider net, where we're getting people with specific health conditions, people who have never worked out before, very sedentary. We can't expect them to start where somebody who's been working out their whole lives, who they're an athlete, where they're starting. And so there's a lot that goes into that, I would say. And if medical fitness really is doing their job, they are getting a lot more than just the fit, the already fit, the athletic. You're certainly going to have that population, especially in some of these facilities that are really nice. The athletic folks, the really fit folks, they're going to see it and say, "Oh, that's a really nice facility. I want to be part of that." They have top-notch equipment, top-notch people, everything like that. But so you're still going to have that, but for us to really have the solution that works, I would say we need to make sure that we're spreading that net. We're making it comfortable for them. We're giving the guidance. Thomas, you kind of boiled it down to that. The guidance factor. So I'll boil it down to we want the wider net. The everyday Joe, and today the everyday Joe has multiple risk factors for all kinds of health concerns. So if we're doing the right thing, we're making specific programs for those people. We're making it comfortable and inviting, that type of an environment, that they feel like they're welcome to come in and they're being helped when they're there. So I'll stop there.
Yeah, it's great. And I think for time purposes today, maybe I'll wrap up this question and then we can plan on having a part 2 of this conversation, because I think that's just what's going to need to happen here. What I'll say about the ideal candidate is my lens thinking about this comes from who needs to be referred. And I think of like which of my physical therapist clients need to be referred to an exercise program. And the first statistic that I'd go back to is 24% of people, estimated by the CDC, report that they meet their physical activity guidelines, meaning they get the moderate intensity exercise, moderate to vigorous intensity physical activity, and do 2 to 3 days of resistance training per week. And I know, the way that I feel about that statistic is it's probably overestimated. I think it's probably a little less than 24% of people. So if I'm thinking as my initial screen of, who could benefit from this, there's at least 76% of the population that I may see in physical therapy that's not currently meeting the physical activity guidelines. And the question that I would then ask is it because they don't know what to do, or do they know what to do and they're just not doing it? And what I can tell you is for most people who are not currently exercising, the knowledge gap is pretty big. For a lot of people who are currently exercising, the knowledge gap is still there. And when we think about who could benefit most from this service, honestly, the market potential is the people who are not exercising, who do not know the survival skills to be independent at doing so in a way that would help them promote their health. And so again, so much of the process of who I refer is from that. Are you exercising? What does that look like? If you did exercise today, would you know what to do? What would be your plan? And if there's not answers to that kind of stuff, and they have a medical condition that would benefit from, health promoting exercise, that to me is who needs to get referred. That's who needs to be in the program. So I want to take a minute, just reflections and wrap up before we jump off. It's funny, I'm actually going to drive really quick out of here. Part of the reason we have to wrap up is I gotta drive out of here and have almost that exact conversation with a group of physical therapists right after this. So But any thoughts, guys, before we wrap up?
Yeah, Thomas, if I can start and just say, I love what you just said. And I really do hope that we can have a part two of this, because what we missed today was the what. And what you just said to me really leads into the what. And as you know, I'm all about creating the whole create an informed consumer as a tagline to, what I do. And I couldn't agree with you more. I think I would go so far as to say that if we could survey somehow the entire population, the world, 8 billion people, that you really just nailed it. That people just don't know how to exercise properly. And it goes back to, again, Dr. Kramer, and he guest lectured for my strength and conditioning students last semester. And the gist of his presentation was, whether it's a patient that has in front of you, a client, or an athlete, you need to have a plan. You need to log the plan so you can collect data. So have a plan, log the plan. The plan needs to be periodized. And for those listeners who don't really, I've been using this term several times. It basically just means make sure that your plan has a long-term, mid-term, and short-term component, where the short-term leads to the long-term outcome, and that it's structured and it's progressive, etc. But the point, now getting to my conclusion, have a plan, log the plan. The plan needs to be periodized so that it's structured and progressive. And most people just go and they just exercise, and they don't really have a plan, and they aren't logging the plan, etc. So, Thomas, I couldn't agree more. And I think that's a major problem. And if we could just get people more informed, it would make all the difference in the world as to who's exercising, adherence, and all the related things. So that's what I wanted to say in my wrap up of this podcast episode.
Well said, Jeff. Yeah, and Thomas too. I mean, and we have so much more we can talk about here. And guys, I'm looking at my screen, and it looks like I'm in like Florida or California, not Indiana. I'm like, why? I'm washed out by the sunshine. It's a wonderful thing to have sun here today. But yeah, I think the how, what, and why. I mean, there's so much more that you can talk about. I do think we could get granular in some of the how and the what, really on how to do things. I think some of our listeners might be coming at it from oh, we do a little bit of medical fitness programming, or maybe we don't do much at all. Others who do a lot of it, but might want to hear more ideas. There's a lot of things that we could go into. So I do think, yeah, that we could follow up this conversation with another. I do think, as it relates to what you're saying, yes, there needs to be more knowledge out there. So I think the medical fitness solution is a real solution for where we are in healthcare right now and all the problems that exist there, where we are from a health of our communities. There's just a lot of solutions that I'm glad to see the industry growing. And the more we can do some of this education and have conversations like this, I think there are many others in the industry, and that's why we do these podcasts. That can lend some of their thoughts and ideas and guidance to the listeners. So I hope this has been helpful for people, and certainly, yeah. Let's have a part two of really diving in even deeper.
Yeah, it's a classic cliffhanger, right? We did a good job unintentionally creating a cliffhanger to this. What I'll say that I'm excited to talk about next time that we didn't get to today, to wrap up the how, we didn't really get into the technology and equipment that's utilized in medical fitness services. And I think that's a huge opportunity that looking forward is going to be a big part of how medical fitness evolves. Beyond that, the what does the actual prescription look like? And I'm really excited to hear Jeff's take and explanation a little bit deeper into that, sharing some case study examples of best practice medical fitness programs that walk the walk, and talking a little bit as we wrap up on, how can medical fitness grow in its reach, and what is going to happen if that's going to become a reality. So for those that found this to be a useful and enlightening podcast episode, that's what we have for next time. And we hope you join us for that too.
Thanks,
Thanks
guys.
so much, guys.
Thanks. This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.